Good morning everyone, thank you for giving me the opportunity to talk to you today about how we have the in-house wait for cardiac surgery at James Cook Hospital. I'll start with a little bit of background about our unit. It was initially set up in 1993 with the purpose of meeting the demands of a large elective waiting list. At the time of its introduction, the case mix was around about 75%, 25% in favour of elective work, and for such reason we had to give priority to the elective waiting list. Over the years, we have made slight changes to our practice, but there's been no fundamental change in practice since the unit's opened. Our lists were often populated. We were meant to have in-house urgent list per day, and cross-cover lists were meant to consist of in-house urgent patients. But due to excessive waiting lists, these were often filled with elective cases as well, and the in-house urgent patients were often cancelled. So to look at the current problem that we faced, we saw a major shift in our case mix. Now it's around about 50-50%, with such there's excessive pre-op waiting times and an increased number of bed days used. We have noticed that there's poor patient satisfaction with the service that we were offering, again because of the length of stay, poor communication, and often the patients were cancelled. As a result, staff satisfaction was at a very low ebb. Myself personally, the surgeons, we were dealing with disgruntled patients and family on an almost daily basis. In worst cases, you would walk into a bay with 5 or 6 patients, all baying for blood, and it was a pretty rotten existence. At that particular time as well, it was a cardiology-led service, which didn't go down very well with our cardiologists, having patients that were referred and accepted for surgery and then remain under their care, sometimes for 5 to 6 weeks at a time. The very fact that the cardiologists were still looking after the patients led to significant problems with communication. Cardiologists would tell the patient one thing when in fact us populating our own surgical lists knew that it was a very, very different story. So we had to go about solving the problem, and making minor alterations to the way that we process things wasn't going to fix the problem. We had to have fundamental change in practice. So we undertook a rapid improvement workshop, and to do this we had to reduce our theatre activity for 3 days, and we invited all the key members of the team to a meeting where we process mapped the current system, looking for bottlenecks in the system and where problems were occurring. We asked each individual team to focus on their particular area of experience. So the surgeons would look specifically at what they were doing, secretaries at how patients were referred and things like that. We discussed changes that we needed to make to practice. We took these back to our team and we evaluated them within the team, and then came back and agreed on a change process that was to take place. And we also made a plan to evaluate the changes that we had made. So what changes did we make? Well, the focus shifted completely from having priority to our elective cases and moving them over to the in-house urgent cases. We changed the way that our theatres were planned, so the in-house urgent cases were given priority on the theatre list. Each theatre list had an in-house urgent case first on that list, and then an elective one after that. We introduced next day transfers from the DGHs and from the cardiology floor, and these patients were then put under the care of a named surgeon the following day. We introduced an electronic referral and scheduling system, which I'll discuss a little bit more in later slides. And as I've said, the surgeons were responsible for the overall care of the patient, but the surgical practitioners took a much more focused role on coordinating and managing the in-house urgent lists. We also changed the way that our thoracic theatre was ran in an aim to reduce the demand on the ITU beds. We basically made one of our 3 lists a purely thoracic list, and again that had a knock-on effect on the number of ITU beds that we needed on a daily basis. So the referral database was developed in-house, and it was an online referral system that was given to the DGHs in our local hospital as well. There was a minimum requirement of information that was inputted to that, including patient demographics, past medical history and brief clinical history of the patient. The system was developed as such that it allowed for attachment of reports such as angiograms and echoes, so it led to the consultant or the registrar, whoever's reviewing that patient, being able to remotely accept the patient for surgery. The portal also allowed us to develop a communication portal where we could input data and the DGHs could also input data onto that, any change in patient conditions, any requests for any further examinations, etc. It allowed us to plan transfers and allocating surgeons to patients, which in turn it generated an automated email to let the surgeons know when the patient had arrived in the hospital, that they were under their care, and all the clinical information was attached to that patient also. So these next slides, this is just a screenshot of the referral database. As you can see, this is what we would see by just opening it up, as a list of all the patients that we have and where they are in the system, whether they've been accepted or they're on hold, and it allows us to plan our day much better that way. When you go in further, this is a screenshot of an actual individual patient. So again, you can see how the database was laid out. So the electronic scheduler, before we developed this system, we were relying upon individual consultants' diaries, which were run by the secretaries. Obviously, that had problem attached to it. If a surgeon or secretary was off on leave, nobody knew what that surgeon had planned. So the electronic scheduler replaced all that, and it allowed us to plan and show what was happening live at that particular time, and everybody from theatre staff to ward staff to secretaries had access to this system. And again, this is another screenshot of what we would see generally: patient details, theatre, operation, and where the patient was located within the hospital. So with any major change in practice comes some cynicism and a reluctance to change practice. People are generally happy with what they are always done and don't want to change. So there was some concerns, and some very legitimate concerns that were raised at the time of this. One of the things was, if we're going to prioritise the in-house urgent patients that we were used to cancelling, what was going to happen with our elective waiting list? People expected that to rocket through the roof and have just the same problems, just in a different place. With transferring the patient so quickly from the DGHs, if we had a prolonged length of stay, what effect was that going to have on our ward beds? Were we going to become overpopulated with patients and not be able to get put through the wards? Obviously, as we've mentioned with the schedule and the database, the introduction of new technology. People like paper, that don't like computers generally. So this was the third part of the audit, 1 year after introducing the recommendations of the RPIW. I looked at 50 consecutive patients undergoing in-house cardiac surgery and retrospectively analysed data from both the operation notes and the referral system that we used. So as you can see, the referral rates that we've received over this time were no different to what they were before we introduced the change. We had a total of 1,090 patients in 2014 and 1,090 patients again in 2015. A slight difference in the way that the patients were referred into hospital, slightly more in-house urgent cases in 2015 than 14. So as you can see from this slide, introducing the recommendations of the RPIW have significantly reduced our pre-operative work for surgery. Back in the bad old days, we were waiting 19 days on average before patients were operated upon. 6 months following introducing the changes, we'd managed to halve that stay, and 1 year following that, again, we'd managed to reduce it even further to a maximum of 7 days. This slide again shows some of the differences between the two systems that we were using. As you can see, there is a big difference between the length of time from accept to surgery and the total length of stay of the patient. There's not much difference in any of the other bits that we looked at there. So the other thing, putting the patients first on the list, what effect did that have on intensive care stay? Well, we have shown a reduction in mean length of stay on our ITU as well. So it's now at 2.2 days as compared to 2.6 days prior to the change in practice. Cancellation rates. We have managed to reduce the cancellation rates because of the ITU bed problems, and there's been little change in any of the other categories that we looked at. These other categories are outside of what controls we had within the RPIW. So the other thing to take heed of is that the change in demand for services. Obviously, you at times you get spikes in the in-house referral rate or spikes in the elective rate as well. And how are we going to cope with that? Well, what we found is if we'd agreed a length of stay before surgery being a maximum of 9 days and patients were going to exceed this, then we would routinely cancel elective patients and put the in-house urgent patients in them slots. Alternatively, if there was a trough in the number of referrals that we received in-house, we would have a short notice elective list that patients would be put on when they attended our clinics, and we would ring these patients at short notice. So we haven't been left with any empty slots in theatre since the change in practice. So again, like I said, that's things that we've already discussed there. We have to closely and still have to closely monitor our elective waiting times to make sure that they're not getting excessive. We're not seeing that happen at the moment. So what effect has this had on patients, the staff and the trust? Well, obviously for the patient, they've noticed a significantly reduced preoperative waiting times. They've much quickly transferred from the district generals into specialised care unit, which in turn leads to better information, more reliable information for the patient, and access to a consultant surgeon and specialist nurses within that area. For staff, I personally have noticed that my work life has become much more improved because you are not going on a daily basis to see patients that are unhappy, family that are irate, and you're not spending sometimes hours with patients trying to pacify them, get them ready for surgery. And also for our ward-based staff, with myself and one of my colleagues, there's a recognised point of contact now for in-house problems. If the ward staff are finding that they're having issues, they can refer straight to us, and if we can't solve it, then we can go to people that can. For the trust, the decreased length of stay obviously leads to a reduction in bed days as well, which has allowed us to close 6 surgical beds on our unit and maintain the same throughput and the same staffing level. We've noticed that we don't have to staff our beds now with overtime and agency staff as well. And it's allowed us to consider, more than consider, we are introducing day of surgical admission from April. All of our elective cases will now be second on the list, which gives us sufficient time to make sure that patients are adequately prepared for surgery on the same day. Again, we will have to see what impact this has on our bed days, but looking at things from the outside, we would anticipate that we're again reducing bed days of patients in hospital. So in conclusion, the Rapid Improvement Workshop has given us a more efficient way of working. We've noticed a decrease in our pre and total length of stay, and our ITU length of stay has also been reduced. We've also noticed that there's been no detrimental effect on our elective cases. And one thing to take from this, if we had to repeat the process again, instead of having the major players involved within the improvement workshop, we would invite a much greater number of people to input ideas and change practice from there on. I'd just like to thank everyone who was involved with that and invite questions from the floor. Thank you.